Welcome and thank you for joining us for our webinar today. Our speaker, Dr. Ami Vanartzi, will review the role of musculoskeletal ultrasound in rheumatology clinical practice, specifically focusing on imaging lower extremities. This webinar is brought to you by Esaote North America and features the MyLab X8 ultrasound system. Our presenter is an accomplished practicing rheumatologist and researcher. Dr. Vanartzi provides patient care while leading both educational and research projects focused on advanced techniques in musculoskeletal ultrasound. There will be time for a Q&A session at the conclusion of our webinar today. Please feel free to type in your questions in the dialog box and we will address them at the end of the presentation. Dr. Vanartzi, you may begin at any time.
All right, thank you. I'm a practicing rheumatologist, and I was asked to give a lecture about the lower extremity. And in rheumatology, you know, we do get to the foot and ankle a little bit, but we kind of focus more on the knee and hip. I feel like we often defer kind of the very bottom part of the lower extremity to podiatry. But if somebody has specific questions about that at the end of the session, I'm happy to take them. And I thought it would be useful to focus on interventions here, because I think that's what a lot of people also want to hear about is injections of the knees and hips. And knee injections seem like they're easy and not complicated, but as I hope you will appreciate, there's actually a lot more complexity to it. So this is a picture of me. It's always, so you guys know what I look like. We're going to start off with some knee anatomy. We're going to talk about accessing the knee joint with an effusion, which is the easier part, large knee effusion with synovitis, accessing the knee joint when there is no effusion present, it becomes more difficult, the lateral recess, and then we're going to finish up with some diagnostic ultrasounds of the knee. And then we're going to talk about the hip, focusing on hip anatomy, what a hip effusion looks like and how you diagnose it, performing a hip injection and a trochanteric bursa injection. Musculoskeletal ultrasound is growing in popularity, and this is a graph from PubMed showing all the publications in musculoskeletal ultrasound. As you can see, year over year, there seems to be an increase in publications and a growing interest in musculoskeletal ultrasound. With that, we're seeing more rheumatologists and other specialists incorporate musculoskeletal ultrasound into their practice. When you start looking at the knee, you want to start with your patient in a supine position, and like so, and obviously place the probe above, over the knee, pointing down at the floor. And when you do that, if we look at the anatomy, we expect to see the femur over here with the femoral condyle, and then the tibia over here with the tibial tuberosity. And we have the hyaline articular cartilage that coats the femoral condyle, and we have the medial and the lateral femoral condyle, and we have some hyaline cartilage coating the proximal end of the tibia, and this is where the bones articulate. To our dismay, we also have a patella. And a patella presents a challenge in the knee because it is a bone and ultrasound does not scan well through bone. So it creates an acoustic shadow and kind of obscures our view of what's happening, deep to the patella. We have the quadriceps tendon coming in over here. We have the patellar tendon coming in over here and inserting into the tibial tuberosity. This is the joint space, and an extension of the joint space is the suprapatellar recess. Some people call this the suprapatellar bursa. Bursa is not exactly the correct term because it is not a separate anatomic entity. It is actually contiguous with the joint space, and it extends all the way pretty far up the knee, and in its most proximal area, it's just underneath the quadriceps tendon. So if you're looking for it here, you'll find it just underneath the quadriceps tendon. Because we can't see through the patella, we kind of leave this area alone when we do a diagnostic musculoskeletal ultrasound of the knee. And we focus on the suprapatellar recess with the understanding that if whatever process is going on in the knee, whether it be synovitis or effusion, would be visible to us here. It kind of spills over into this bursa. And accessing this area becomes easier because we can see through all the soft tissues here, and actually safer because you can imagine if we're inserting a needle under the patella over here, we're risking, and studies have shown that this actually happens, scratching the articular cartilage on the bottom of the patella or scratching the bones and other things going on over here. And we don't have to worry about, touching the bone with a needle when we access the suprapatellar recess. So now we're going to superimpose an actual ultrasound image on top of all of this and take away the cartoons. And this is kind of what you get. So this is obviously a composite of multiple images. And you're seeing here the quadriceps tendon coming in and inserting on the patella, then the patella, and then we're seeing the patellar ligament, which connects the patella to the tibial tuberosity over here. There's a small bursa deep to the insertion point, which sometimes you can see and sometimes you can't. You'll notice again the patella is casting an acoustic shadow over here, so you can't see the stuff going on under the patella, but you know that there is a femoral condyle with articular cartilage underneath here. And the suprapatellar recess is this very fine dark line that goes under the patella and is contiguous with the joint space. And this is what a suprapatellar looks like when there is a effusion present. So we can see over here, and I'm going to play this video as of myself scanning through this, okay, in long, and now short axis. So we flipped around the probe, and we have now here the quadriceps tendon in cross section, and we're going to see a needle now come in and access the space. So the needle is coming in from the lateral aspect of the knee here, and we're able to drain, or inject the suprapatellar space. This is, of course, kind of ideal conditions because you have a nice big effusion to aim for. When you start doing these ultrasound guided injections, you want to pick a knee like this. And over here, we see a very large effusion. It pushes up the quadriceps tendon. Notice the scale over here. Okay, so the effusion is about 2.5 centimeters, about an inch that you have to work with over here. And this is in the short axis, the same effusion. So over here, we see now the quadriceps tendon is over here. And you'll notice that I kind of place the probe more on the lateral aspect of the knee. I don't place the quadriceps tendon right in the center. I found that this is a better way to access the knee. So the probe is slightly on the more lateral aspect over the effusion. The femoral shaft can be seen down here in the long axis and can be seen down here in the short axis. And there's prefemoral connective tissues. You don't want to touch these tissues with a needle. They're very sensitive and the patient will jump if you put a needle through these tissues over here. I use a generous amount of local anesthetic using a 27 gauge needle. Insert the needle from the lateral aspect once the patient is anesthetized. And one of the things you're going to appreciate throughout this presentation is that I take my time about it. And that's the reason you really want the local anesthesia there, because to do a ultrasound guided procedure well, you don't want to be rushed. You need to line up the probe with the needle. You want to advance the needle slowly while you're visualizing it. You may have to make adjustments in the angles of the probe. And so you want the patient to be comfortable and not kind of squirming as you're doing that. So this is the kind of knee you want to start with because it gives you a really nice large target to aim for. Now, you may say, for a knee like that, why do I need ultrasound guidance? I can drain that knee blind. But I will tell you that this is that same knee once it's drained, and what you will see in this video is that with ultrasound guidance, you're really able to drain it to the very last drop. And this is not something that you're going to be able to do without ultrasound guidance. The needle here, again, I'll alert you to the scale of things. This is just 1 centimeter. So the needle here is in a space just 1 or 2 millimeters. And it's still draining and draining and draining, until the effusion is completely gone. So this is a reason to use ultrasound guidance, even in a situation where you can clearly access the effusion without it. Now, this is a more kind of typical scenario. Over here, the effusion is not as prominent. You'll notice that it's only about 5 millimeters across. Again, everything looks big on the ultrasound, but you have, that's thanks to the good machine that we're using. But in real life, this is not a big space, and we see some small effusion here in cross section. So this is, again, long axis view, short axis view. We're kind of taking a cross section right around here, of the suprapatellar recess. So we have the quadriceps tendon over here, and we see some tissues here. And I want you to note now this little hump here. And this is going to now be a recurring theme because in the lateral aspect of the knee, there is this little fat pad, and this fat pad will become useful for us for identifying the suprapatellar recess when it is difficult to identify. And so this is that same knee, and you'll notice now the needle is coming in. It's coming in kind of angled up, and that's a common thing that you're going to want to do when you insert the needle, kind of angle it up towards the probe to get over this little fat pad over here, and then and now you can aspirate the fluid. And again, this looks like a big target, and this looks like a lot of fluid, but we're actually only in 5 millimeters, working in 5 millimeters here, which is not very much. The other thing that I want you to pay attention to is the fact that there is some gray material over here. So this patient has a small amount of synovitis, and this synovitis without ultrasound guidance can get in the way of the aspiration, and you wouldn't know it if you didn't have the visualization. And these are, again, these peripatellar tissues up here, which if you just kind of stick the needle straight in there, the needle may end up inside these tissues. This is both painful for the patient and of course ineffective when it comes to accessing the knee joint. And over here, this is a PRP injection, so you can see the PRP now going in, and we know that we're in the joint space because we see it kind of shimmering all the way on this end of it, and we're seeing the suprapatellar recess now kind of re-expand with what we're injecting into it after draining it. And once more, you have this little fat pad over here. This is not to be confused with synovitis. This over here is synovitis, this darker gray kind of area. But this is this normal fat pad that patients have, and can be a useful landmark. So with that in mind, these were examples so far of pretty straightforward effusion without a significant amount of synovitis. But what happens when we have a joint with more synovitis? And you may say, oh, synovitis, we don't get that a lot. But if you start doing ultrasound of knees, you get to appreciate that even in osteoarthritis, there's a lot of synovitis in the knee. Sometimes I see suprapatellar recess that's just packed with synovial tissue, even in osteoarthritis. And this phenomenon has been described. And in that case, you really do want the ultrasound guidance to know that you're avoiding the area of synovitis. Over here, we see it doesn't take a lot, but you see this little kind of gray little synovial front here that's kind of blowing in the wind now as we're trying to aspirate. And every once in a while, it'll kind of, plug up the needle. The needle kind of catches it, right? Because we're putting negative pressure and the flow can stop. But I can see that that's what's happening, and I can just kind of reposition the needle a little bit and still keep the aspiration going. I know that I'm in the joint space. I know where I want to be. Again, this speaks to all of those scenarios where you palpate and you know that there's fluid in there. You put your needle in there, you're trying to aspirate, and you can't get any fluid out. So these kind of situations happen that explain that. Once more, a moderate knee effusion, and we can go there. It looks very obvious where the effusion is over here, but again, we're working in a very small space, only about 5 millimeters, but we can go and we can drain it from the lateral aspect. We're looking at it in short axis over here, and then injecting over here Depomedrol into the knee. When you see this very bright signal over here that casts a shadow, that's air. Okay, so there's a little bit of air bubbles there, and the air floats to the top, and that's fine. You can see the Depomedrol again kind of shimmering all the way over here in the more medial aspect of the suprapatellar recess. Okay. And here is a situation where we really have a lot of synovitis. So over here now we're scanning through a suprapatellar recess. You can see how distended the recess is. This is the tip of the patella over here. This is the quadriceps tendon. And look at all of that excess tissue. It's all filled with tissue, not with fluid. Little bit of fluid up here, but not much. All this is synovial hypertrophy. And this is actually a case of osteoarthritis, not an inflammatory arthritis. And when we wish to aspirate a knee like this is where we really want ultrasound guidance, because we're maneuvering through all these areas of synovial tissue, trying to get to a little pocket or a pool of fluid over here. And this is where a long needle is helpful. Keep in mind the patient does not feel more pain because the needle is longer, because the needle is in a space over here, and we're able to aspirate the fluid. Now we're coming in from the lateral aspect, but the needle is reaching all the way to the more medial aspect of the knee here, because this is where this patient's fluid is at. The lateral aspect is more packed with just synovitis, and you have the quadriceps tendon here above. Now, what happens, we're going to go to the next kind of challenging scenario when you don't have really much of an effusion to aim for. And here we have a knee, and you can kind of make out the suprapatellar recess over here in the long axis view. In the short axis view, it becomes a little tough. You know, we know the bone is down here, we know the quadriceps tendon is over here, but which of these dark lines represents the suprapatellar recess? And this is where there's a nice little trick that I like to use, which is to poke at the knee from the lateral aspect with my finger. So I just kind of press with my finger repeatedly at the knee to try to displace the tissues while I'm looking with the ultrasound. So the probe over here, the transducer is in short axis view, and we're looking for that little hump. Do you see that little fat pad that I mentioned earlier? We're looking for that fat pad. We know that right over that fat pad is where the suprapatellar recess is. Sorry, I flipped too soon. And this is where you want to go. And then the other clue is if you're a little actually further away from the patella, more proximally, we know that the suprapatellar recess is going to be right under the quadriceps tendon. But I really like to use this fat pad as a marker, so you can kind of see it over here. And I'm going to demonstrate what that looks like in this next video. So here I'm kind of poking. You know, so you're poking, and you can see that the tissues above where the tendon is are kind of staying still, and the tissues below are being displaced. And you can kind of see where there's a tissue plane right along here, where the tissues below, I hope you can appreciate this, are being displaced where the tissues above are not. And that defines for us the suprapatellar recess over here completely collapsed, but that's where you want to kind of thread your needle into. This is, of course, a little more advanced, so you want to take on these kinds of cases only once you're comfortable with accessing joints with an effusion. And these are more examples of the same technique. Over here, we see that little fat pad over here, which again is being displaced as I'm just poking with my finger, pushing with my finger to demonstrate. And, you know, it makes the suprapatellar recess here a little more visible. And then once I kind of make out where this line is, now I can go in with my needle. I'm kind of climbing up over that little fat pad that we identified over here. And I can feel that I'm in the space, because once I try to inject also, I see that what I'm injecting is not encountering any resistance, you know, just kind of flowing away and disappearing. It's not collecting by the tip of the needle. And another good clue that you're doing things right is that the patient is not complaining of pain. You know, if you ever pushed something into the suprapatellar recess, and as you're pushing the needle, the patient says, ow, 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 then that means you're probably not in the space. You're actually in some soft tissue somewhere, because as you're injecting, the patient actually shouldn't be feeling anything. So this is an example of accessing a knee joint where an effusion is not present, which is a little more challenging, but can be done with practice. Sorry, I think actually I had, let me see, was this the same one? Yeah. So another trick for cases when you don't see an effusion in the long axis view over here is to look for a fluid collection in the peripatellar gutter. So there is this space that's contiguous with the knee joint, just lateral and medial to the patella, and you want to place your probe in short axis with one end of the probe just kind of falling off the tip of the patella in the lateral or medial aspect, and the other probe kind of pointing down towards the floor, you know, in the direction of the floor. And so what we're seeing here is the patella would be up here. We're looking, and this is a short axis view. The femur would be down here. We have some prefemoral just connective tissues. And then you see this teardrop looking kind of area of fluid. It's kind of like the fluid is kind of dripping off to the side of the patella, but that area is actually contiguous with the knee joint, and that's another place where you may want to access the knee. And this is what that looks like. Again, this is the patella over here, the femur down here. We see just kind of oozing out from under the patella. You have this area of effusion. So this is anechoic, so it's an effusion. There are some ligaments up here that you're going to have to go through to get there, but you can both aspirate and inject this area. And this is an example of hyaluronic acid injection to that lateral recess. You'll notice again, I'm advancing the needle slowly. I want to make sure that I'm seeing the needle. If I would to pierce a little further, I would be inside these tissues, but I can see here clearly I'm in the space, and you can see the hyaluronic acid kind of filling the space, and you know that it's going to make its way under the patella and make its way to the knee if you put it in here. You may say, well, Dr. Banarzi, there's a bunch of fluid here. Why didn't you drain the fluid? But when you really think of how much fluid is in here, we're talking about, 1.5 centimeters by 5 millimeters. This is like 1 cc of fluid that we're looking here. Very small amount, not of any clinical significance. Oops. Over here, we have another example of a larger peripatellar fluid collection. So once more, the patella is here, and we're putting in the needle, and we're seeing this kind of teardrop collection of fluid, which is contiguous with the knee space. And we're working in the very lateral aspect of the knee here. Over here, we see the beginning of that fat pad I mentioned earlier, and over here it's covered with some synovitis, so that more hypoechoic, kind of more friable tissue, and you can see how it's moving is synovitis. With that, I covered, I think, the knee injection part, and now I want to transition to talking a little bit about diagnostic ultrasound of the knee and the anatomy. Over here, we have an example of osteoarthritis. We see here what a normal medial knee looks like. To get this view, you're putting the probe in long axis, so along the same axis of the leg, in the medial aspect of the knee, at the area of the joint line where the tibia meets the femur. And this is actually about the level of the patellar ligament there, where, so you're below the patella. You're actually more distal than the patella. You're at the level of the patellar ligament. If you see a picture like this, that's fairly normal. You'll see a pretty sharp corner over here and a smooth corner here. And this is the tibia, this is the femur, and then the meniscus is this kind of wedge that's sitting here, and the meniscus is kind of nicely tucked in there between the two bones. What happens in cases of osteoarthritis, and these are two examples of osteoarthritis, is you'll see osteophytes. And again, you may say, whoa, these are huge osteophytes, but the scale, this is only 3 millimeters. So on an x-ray, this may not be very obvious, but on the ultrasound, it is very obvious that there's an osteophyte here. There's also a small osteophyte on the tibial side. And we see that the meniscus kind of gets pushed out, so we call it extruded. The meniscus is kind of extruded from its place. It's kind of being pushed out. Over here, this is even more prominent with the meniscus really getting pushed out of the joint. You can see the bones are probably touching over here. And this is once more where the femur meets the tibia, and osteophytes present on both sides of the joint. So when you see this, this is osteoarthritis of the knee as seen in the medial aspect. In the lateral aspect of the knee is anatomically more complicated, and so that's considered a little more advanced, but you can also see osteophytes here. There is this natural kind of groove in the side for the popliteus tendon that runs over here. So I recommend that you kind of tackle the lateral aspect of the knee once you're comfortable with the medial aspect. This is an example of a more normal lateral aspect, and you see a meniscus right there, this kind of triangle. And over here, the meniscus is not as visible, and we see osteophytes on both sides of the joint. We're obviously very interested in rheumatology and orthopedics and a variety of other specialties in the articular cartilage. And the articular cartilage gets tricky because we have the patella obscuring it. As I said, the patella casts an acoustic shadow. So we have to employ a trick to see it. We ask the patient to bend the knee, and by bending the knee, the patella actually kind of stays with the tibia and slides forward. And now we get a window into the articular cartilage over the femoral condyle. We actually like the patient to bend the knee as far as they can. So if they're able to touch their heel to their butt, that would be ideal. But you kind of, work with what you got. And then you place your probe in the short axis position, just pointing straight down towards the floor. And then you expect to see some of this hyaline cartilage here. And I call it the seagull, so it looks like a seagull over here. You have the medial and lateral femoral condyles covered in articular cartilage, which should be anechoic, should be very dark. If you have some fuzzy margins, that's actually early signs of cartilage deterioration or early degenerative changes in the cartilage. And also we talk about loss of anechoic signals. So if there's some grayness to the cartilage, that's considered pathologic, but these are all very early signs of cartilage degeneration, which are likely asymptomatic. There may be an interface sign outlining the cartilage. So if you see like a really bright line on top of the cartilage here and here, that may be normal. That's just a normal artifact of ultrasound. And you want to differentiate that from the double contour sign, which indicates gout. But this is an almost normal knee over here. This knee, however, has some pathology. So first of all, we notice that the cartilage is very thin, and in some places almost absent. And secondly, we notice that there's some bright signals within the cartilage. And this knee actually has CPPD, or calcium pyrophosphate disease, which may cause pseudogout. As we scan more proximally, the cartilage becomes thicker over here. The quadriceps tendon, incidentally, is above. And as we scan more distally, so we're getting to the part that's more the articular cartilage, the cartilage becomes very thin and embedded within the cartilage's hypoechoic signal. So again, we started the scan over here and we kind of moved proximally. So when we got to this area that doesn't really articulate much with the tibia, the cartilage got thicker, it didn't get worn over here. But then as we we're sliding the probe more distally, we're seeing the cartilage just get thinner and thinner, and we see those CPPD crystals embedded within the cartilage. So this is another way to diagnose two pathologies here: osteoarthritis and CPPD. I want to now shift gears, and we're going to move on to ultrasound applications for the hip. We're going to start by reviewing just a quick hip anatomy, then look at what a hip effusion looks like, review hip injection, and then trochanteric bursa injection. So in order to image the hip, we have the patient supine. You want to use a curved probe is preferred in the scenario, and you'll notice we're using a curved probe. That gives you a much bigger kind of field of view. You can use a linear probe here if that's all you got, but it's just going to be a little harder to see things. You're going to get a kind of smaller window to look at the joint, and you're looking at kind of a big joint. So it's kind of like trying to make out what's in a room by looking through the keyhole. You place the probe in a long axis position. Sometimes you need to tilt it slightly with the distal end of the probe pointing out or more laterally, and the medial part of the probe pointing more medially. But I find I'm usually able to get a nice view with the probe pretty much lined up with in the direction of the body of the patient. And what you're looking for is this kind of picture. So we have the acetabulum, which is part of the pelvis, meeting the femoral head, and then the femoral neck over here. And the hip joint space is actually this colored area here. And this is the part that you want to access. Now, within the hip joint, so this is an example now of a hip joint. So we have again here the acetabulum, the femoral head, the femoral neck, and this is the joint space. And I picked this picture because over here there's actually an effusion, which we're going to talk about in a minute. So the joint space is accentuated. You can see here, you can make out a dark line and a white line that outline the joint capsule of the hip. And if you can insert a needle going from distal towards proximal, you can access this area. You want to aim when you do hip injections. You want to aim in general for the neck over here of the femur. And that's going to be the safest and best place to inject. In a patient without effusion, this space is maybe filled with kind of just fatty tissue, which is normal. It can be kind of a fat pad that's inside the joint itself. And if you're having trouble injecting, my recommendation is either to try to just pull the needle back a little bit. I mean, you have all the space from here to here, and you're still inside the joint capsule. If you are injecting cortisone, the cortisone will get absorbed and will affect the joint. Even if it's injected into the fat pad, it'll still work. Or the other option is to try to get the needle kind of more proximally into this area. And if I'm having trouble here, then I have more success here at kind of seeing what I'm injecting kind of flowing into the joint space. But usually I kind of aim for here first. This is where I try. The risk of kind of accessing this area is over here. You already have the articular cartilage coating the femoral head, and you risk damaging the cartilage with your needle by kind of pointing it in this direction. So ideally, you want to be over here. I basically insert the needle until it just touches the bone, then I withdraw back a tiny bit, and then I inject. A hip effusion is, assessed by measuring the distance between the femoral neck and the joint capsule, and we're looking for a distance of less than 7 or 8 millimeters. And in this case, if you look over here, this is 1 centimeter, 10 millimeters, and we're about 13 millimeters here across. So this indicates that the patient does have a hip effusion. The joint capsule is distended. This is a different hip over here. We have like a small osteophyte on the acetabulum over here, and we can kind of make up the joint capsule. You can see where the dark and lighter, so you can kind of draw a line here like this. So this is the joint capsule over here, and the angle here. And so this is going to be an example of a hip injection. I use a spinal needle for this. I believe 23 gauge or 21 gauge spinal needle, and take my time. Again, I use local anesthesia before I do this, so the patient is numb, they're not feeling this, and kind of aiming for the bone down here. And once I feel that we have kind of touched the bone there, so I feel that I, touched the bone with the tip of the needle, I just pull back a little bit and inject right there. And I believe this is an example of the actual injection, and you can see that what I'm injecting is expanding the joint capsule, so all looks good. This is an example of accessing that hip effusion that I showed you earlier. And as you notice, again, I'm taking my time to make sure that I can, to the best of my ability, see the needle. And you can see the needle tip right now is down here. Okay, so I'm definitely in the joint capsule, just next to the bone. And after I aspirated, then I injected some Depo-Medrol into this area, and you can see it filled the joint capsule. And there's the needle tip right there, and we withdraw the needle. So the needle is coming in from the more distal side of the probe towards the proximal side. There is some literature about a very small arteriole that tends to pass in the path of the needle, and there have been people that have recommended putting a Doppler box on here to try to find that arteriole and make sure you avoid it as you kind of access the joint. In my experience, that has not been necessary, and I don't really know anybody that does these injections that actually does this or worry about that little arteriole, but I just wanted to put it out there in case you've heard of this. And the last scenario I want to bring up with you is injection of the trochanteric bursa. To get this view, you lay the patient on their side, and I use a linear probe over here. I may use a curved probe if the patient is extremely obese, if they're really large. But for most patients, even slightly obese patients, the linear probe, works fine. And I place the probe in the long axis, so along the same axis as the body of the patient, over the greater trochanter. And we're looking for an image that looks kind of like this. What we're seeing here is the greater trochanter, the bone down here, and then the two gluteal tendons that insert here, the gluteus minimus and the gluteus medius. And there is a bursa between them that you can see as this very thin dark line. And there is another bursa also over here, kind of separating the gluteus minimus from the bone. And we know that, trochanteric bursitis is really a misnomer. Most patients who come complaining of pain over the greater trochanter have actually tendonitis or tendon pathology in one of these two tendons. And you can have calcific tendonitis, garden variety tendonitis. You can have tendon tears and other pathologies here. Most patients do not have actually true bursitis, but we call it all bursitis. Because it's often hard to say what anatomic structure is causing the pain. In my experience, about half the times when I look at these, they look normal to me, even though clinically the patient seems to have something bothering them there. Half the time I do see pathology with a tendon being inflamed, or fluid in the bursa, or a tear in the tendon, or calcifications there, or cortical irregularities at the base here. But if the tendon is, if everything kind of appears normal, I do believe that there's probably something wrong here. And so I'll just inject everything. And what I'll do is I'll kind of get the needle down here again, usually using a spinal needle, because this is a deeper structure, especially in people that are a little overweight. And then kind of peppering the area with cortisone and using the opportunity to do a little maybe prolotherapy. So for those of you familiar with prolotherapy, traumatizing the area in order to induce healing. So, you'll pierce down here, inject some here, pull the needle back, change the angle, inject a little here, inject a little here, inject a little here, pull the needle back as you're pulling the needle back, and kind of hit a few spots throughout all these layers down here. And this is a video of that. So the needle is here, and you can see some depomedrol going in here, and I'm kind of injecting as I'm withdrawing the needle. You saw some go into the bursa between the two tendons, and now I'm back down here again. And as I'm withdrawing the needle, I'm injecting along the way. So it's going through the tendons, through the bursa, and there's an opportunity to inject just a little bit of everything. There you can see the needle. And over here is the bursa and the tendon being injected. And with that, I will open it up to questions.
Excellent. Thanks again, Dr. Benartzi, for your insights today. We will now take question submissions through the question dialog box. We do have one regarding that, the slide you were just on for the bursitis injection. Was that a sonographic needle?
No, it was not. So this is just a regular spinal needle. The angles that you're at when you're doing the bursa injections can make visualization of the needle more difficult because the needle is in a steep angle with respect to the transducer. I have not had any trouble with that in general. I mean, I managed to see what I need to see, but if you are more comfortable using a sonographic needle, which is kind of etched to give you a better view of the needle, then by all means, I recommend that.
Great. Okay. When you are using ultrasound, and I guess specifically the ultrasound you're using here with the X8, what are some best practices or the settings that you've used on hard to image joints with the system?
Good question. So one thing that I found is very important is to place your focus points in the right place. That can make a big difference in the quality of the image that you get. So pay attention to where the beam is focused. I found that if the beam happens to be focused on, superficially, but what I'm really interested in looking at is, 2 or 3 centimeters below the focus points, the image is not going to be as clear. And by just lowering the focus point, then you get much better quality image. So pay attention to that. I use so I have a linear probe that goes up to 15 megahertz, and for knees, I usually drop the frequency to 1 below the highest, so it scans up to about 12 megahertz, and I get good images with that. But sometimes if I have a knee where it's very deep because of obesity or whatnot, then I may need to go even lower on the frequency there. So don't be afraid to drop the frequency. As you drop the frequency, you probably will need to reduce your gain because the image will be brighter. And then make sure the focus point is at or below the area of interest in the image itself.
Okay, perfect. Also, can you go further and expound on any tips and tricks you use to differentiate pathology and tissue within an ultrasound image for those that aren't quite used to it?
For different kinds of tissue within an ultrasound image? Sure.
Yeah, so just differentiating between the two.
Yeah. So we have different kinds of tissues that we can see with the ultrasound. This is an example over here of a tendon or ligament, which tends to have like very fine striations, very fine stripes in it. And it's probably seen better in some of the knee images. So let me go back to those. So when you see a structure like this, where you can kind of make striations across them, so you're looking at a tendon or a ligament. They have the also unique property of anisotropy, which means that they can go light and dark when the angle is changed between the probe and the structure, the ligament or tendon, and that's a feature trick that we sometimes use to identify them anatomically also. Fluid is obviously anechoic. It should look black on the ultrasound image. Synovitis is kind of a hypoechoic, which means a dark gray kind of tissue, kind of like what we're seeing here maybe. And then when you see kind of brighter gray tissue, those can either be fat pads or just kind of amorphous connective tissue, and usually is more indicative of normal tissue rather than pathologic tissue when it's associated with joints. The pathologic tissue tends to be more hypoechoic, tends to be darker. And we can see that here. And then fat or subcutaneous adipose tissues, I always say reminds me of clouds. So when you look at like this area, you kind of get these swirls of more hypoechoic tissue, and sometimes even with these little dark and light outlines to them, and that is subcutaneous fat. And then over here we have the dermis and the epidermis all the way at the very top here. So those are the different kind of structures here. So this is from here to here is adipose tissue, and you see fascial planes within the fat, which is kind of typical. And these swirls, again, that look like clouds. Then we see the striations of the tendon. And then we see just kind of a, gray, more homogeneous looking tissue down here, which is just kind of connective tissues. Again, when you see a darker tissue like this, it's either synovitis or fat. I mean, just adipose tissue can also look dark. And this, knowing the anatomy, this is actually that normal fat pad, that little lump of fat at the lateral aspect of the knee.
Excellent. Okay. Do you find that trapezoid imaging is helpful, and why do you use it?
So I do find that it's helpful if I wouldn't have had the curved probe. So I think once you have the option of using the curved probe, then the trapezoid image is not as necessary. But if all you have is a linear probe, then you're really happy to have the trapezoidal imaging and to have that ability. Of course, another advantage is that with the trapezoid images, you can have the benefit of the high frequency of the linear probe with the broader view of the curved probe. So you kind of get the 2-in-1, which is really nice. In my practice, and this is just my habit, I've gotten used to using the curved probe whenever I need kind of the bigger field of view. So I haven't gone much to the trapezoid view, but it's definitely nice to have and a useful feature in the Esaote machines, to have that capability, because it does kind of convert your linear probe into a pseudo curved probe. It gives you that bigger field of view, which you would need if you're going to access hips, and also for shoulder injections. I find it very useful.
Okay, great. And then the question too about the panoramic view. Do you find the measurements to be accurate and useful?
Panoramic view, again, part of this is I'm just old school, and the machine can do all kinds of really cool things that I don't fully take advantage of, and I should. So I don't tend to use it a lot, but I think it is a useful feature to have when you need to have bigger fields of view. I have not tried to measure things using the panoramic view, so I can't really comment on the ability to measure things in the panoramic view.
Okay. Also, this is more of a clinical question, but about injections in general. So, when using or choosing between hyaluronic acid and cortisone versus only using PRP, I guess the question is basically like, why would you use only hyaluronic and not PRP, or why would you use cortisone instead of PRP?
Okay, so
speak to that a little bit.
Sure. So I like to offer cortisone to most patients, I feel like if they need some kind of knee injection, and by need, I mean that they're having more acute knee pain, just off the bat, then cortisone is usually the correct thing to offer the patient. I feel like cortisone is going to be more effective at reducing pain off the bat than the other agents, and it's more appropriate for acute situations. When a patient presents with kind of more chronic symptoms and not in a exacerbation or flare of their condition, then I think it's okay to consider either hyaluronic acid or PRP. Um, PRP and hyaluronic acid, I feel like don't work as well in a knee with large effusions. So if the patient comes with a lot of fluid in the knee, I like to recommend first aspirating the knee, injecting the steroid, trying to have the patient do some physical therapy and get the knee to kind of a better place, and then have them come back 2 or 3 months later for a follow-up hyaluronic acid or PRP injection. So we may kind of have this stepwise approach where we start with a steroid to just suppress the inflammation, reduce the effusion in the knee, and then follow it up with the hyaluronic acid or PRP, which are going to be more effective in a quote-unquote dry knee. If you inject hyaluronic acid into a knee with a large effusion, it's probably not going to work because the hyaluronic acid will get diluted by the effusion and it won't be effective. PRP, a little less of an issue, but still a concern and still less likely to be effective in a knee with a large effusion. The problem is that if you just aspirate the effusion, if you did a really good job aspirating it and then you inject it with, let's say, the hyaluronic acid, probably the effusion will come back within a day or two before the hyaluronic acid got a chance to have its, to exert any anti-inflammatory effect. So sometimes you can even combine the hyaluronic acid and the steroid. So I do that sometimes. I'll take 20 milligrams of Kenalog, which is a very low dose for a knee, and inject it together with the hyaluronic acid, and get that way suppression of the inflammatory, state of the knee, followed by the hyaluronic acid efficacy, which lasts longer and is safer. And of course, in the long term, you don't want to inject cortisone again and again and again and again into the same joint. That will probably accelerate the degenerative arthritis in the joint. It'll just make it degenerate faster. So I tell patients, let's try to save the steroid injections for when things are really bad, when we're desperate, because we know steroids will work. But if we can get away with using other agents, that's preferred. And again, and those agents are preferred, especially when you have a knee without an effusion and a knee with more chronic stable symptoms as opposed to an acute exacerbation. I hope that answers the question. And I guess between hyaluronic acid and PRP, I could say a word about that. There have been several studies comparing the efficacy of hyaluronic acid and PRP. PRP has shown to be, was successfully shown to be non-inferior, but not clearly superior to hyaluronic acid. But definitely not inferior to hyaluronic acid, and probably lasts longer. There is some literature from mostly veterinary medicine showing that PRP may have regenerative properties or reparative properties on the cartilage of the knee. I don't tend to oversell that because I think that the evidence for that is very limited, and we don't have very clear evidence. And in most patients with osteoarthritis, they have really large areas of cartilage that are damaged, and I don't believe that the PRP can really heal large areas of cartilage that are damaged. If there is like a very focal defect, maybe there, the PRP can lead to some healing. But the nice thing is we know that the PRP definitely does not cause accelerated degeneration the way steroids may. So it's safe from that perspective. And PRP tends to last 9 to 12 months as far as its anti-inflammatory effect versus just about 5 to 6 months for most forms of hyaluronic acid. So for maybe younger athletic people or just people that ask for it, I'll give them PRP. I found that PRP sometimes works for some patients better than hyaluronic acid, but it's not a panacea. I don't feel that it's for everybody, and I tend to recommend it more to younger, healthier patients who really want to avoid knee surgery and who have a non-inflammatory phenotype of knee osteoarthritis, meaning without a significant effusion.
Excellent. Great. Thank you so much for that. Well, I think we'll probably wind up stopping there just simply because we're running out of time. But if you have additional questions, please email me, stephanie.cantor@esaote.com, and I'll be happy to forward on your questions. Also, this webinar is recorded. We will have one available for you on our website, where the previous webinar was also posted. As soon as that's ready, I'll send a link out to everybody that was on the distribution list that was registered. And thank you all so much for joining us. And on behalf of all of Esaote, I hope that you have a great rest of your day. And thanks again, Dr. Benartzi.
Thank you.